for joining us tonight. I'm Chrissy Groenwegen, and tonight we welcome you to Navigating Your Way Through Treatment and Insurance. Tonight's speaker, Lauren Fink, is the Senior Director of Policy for the Kennedy Forum. She representing the forum on state and national mental health and substance use disorder coverage and advocacy efforts. She works with government leaders, regulators, policymakers, and consumer and industry stakeholders around healthcare access and consumer rights, including insurance coverage, crisis care, and youth and school mental health. Her work led to the successful passage of a number of comprehensive state mental health consumer protection laws that have served as models and been replicated in other states. We are so happy to have Lauren with us tonight to give us an overview of the barriers you might face when approaching mental health care treatment and insurance options. And we are going to have an extended Q&A. So for now, I will turn it over to Lauren. Thank you, Lauren.
So I'm a social worker, trying to provide services to families, and then I later worked for the state court system, and just found a lot of the safety net happening in the judicial system instead of in the healthcare system, and lots of families who were sort of desperate to get their kids help could only do that once they were sort of fallen through, in law enforcement and the judicial system. So that's where a lot of my career started. I came onto the Kennedy Forum almost 6 years ago now, I think, and that was to run a state bill guaranteeing comprehensive mental health and substance use disorder coverage. Oftentimes we talk about them as parity bills. Our founder, Patrick Kennedy, was obviously instrumental in a lot of these commercial coverage and insurance parity bills. What I would rather kind of frame this as tonight is really like comprehensive mental health and addiction care coverage, and how you can kind of advocate for that on the commercial side, for those of you who have employer-sponsored plans and things like that. So it's a very complicated web. I feel like because of my job, I'm often taking calls and things from friends and family, trying to figure out, this is the letter I have, here's the denial, kind of what can I do next? And I know that a lot of you have probably dealt with that one or numerous times, and you only need to deal with it one time to completely be infuriated by how the system works. So I'll talk a little bit today about some of the areas that I think are most important for self-advocacy and sort of getting coverage for mental health and addiction services covered to the full scope that they should be. I'll try not to get too much into the weeds of parity laws and things that might make you fall out of your seat bored. So hopefully this is important to you all. One of the things is that every state has a different way of regulating health insurance. For the most part, state insurance regulators or commissioners are the ones regulating state regulated commercial insurance. There's also federally regulated commercial insurance, so ERISA plans, a number of employer-sponsored plans, things like that. And it's really hard sometimes to tell whether you have a state or a federally regulated plan. If you don't know the answer to that, it's worth asking your benefits manager, or even just asking the state regulator. If it's not in their purview, they'll tell you it's not ours, and then you'll know it's a federally regulated plan. So that's the first place to start, because you know kind of who your first step is. And I'm just going to assume when people are dealing with denials and things. So the first part is you get a denial, or you get even a partial denial or a delay where they won't give you information. Those things I know are very common. The first part is to start with an internal grievance or appeal. And a lot of times I recommend that people say that directly, like, I am starting an internal grievance. I'm starting it, because these words mean very specific things to the insurers, and there's certain timelines and laws they have to abide by to get back to you. A lot of times they'll just try to call you, and you can get some answers on the phone, but as we all know, it's very hard if they've promised you something on the phone, but you have no documentation of it. So I always recommend that folks send an email or send written correspondence or use these terms in order to kind of get those protections in place. So first thing is starting an internal grievance or appeal with your plan. If they have some, and at that point, they may re-look at your case and say, never mind, we are covering it. If they don't, then you can move, and you can say these words too, move to an external grievance or appeal where you're asking for basically a third party to take a look at that, and they have to give that to you too. If that doesn't work, you can then bring your appeal to I'm just going to use the state regulator. It's to start with, to the state regulators. And oftentimes they have like a consumer focused part of their websites, and you can add all that information. One of the issues that often I think comes up is, and it's very annoying, and I have many opinions about why it shouldn't be this way, but it often is this way, where the regulator will say, okay, give us your information so that we can, have the evidence for your appeal. Then they will take that information back to your health plan and they will say, this is what they gave us. What do you have? And then the health plan will give them all sorts of information, part of which you may not even have had. And then sometimes they'll reach back out to the consumer, but sometimes they won't. And then all of that decision making will have been made without you kind of getting an opportunity to give, or your provider giving you an opportunity to give all that information. So I tell people I recommend getting as much of your paperwork and ducks in a row, and submitting on that first try, with the regulator as possible. There's a few laws in place so that are necessary. So there's the Federal Parity Act. There's also the No Surprises Act, which I think can be really helpful for surprise bills, but also for the information that you are entitled to as a consumer. And so you can kind of get information on your appeals and things. The Consolidated Appropriations Act of 2021 was a very important one too, because it also allowed for state regulators to ask for what we call parity compliance analyses. And I don't need to get into what they are, but as part of that, you kind of have they have to explain why they're the reasoning behind their appeal, and you as a consumer can sort of ask for that reasoning as well. So that's a big piece that I think is important, is to say, as a consumer dealing with a denial, you are entitled to know why and have written documentation from your health plan on why they are denying you. And then you kind of start to work with the information that you have. So a lot of times it'll be medical necessity. A lot of times it'll say that's not the what we call a generally accepted standard of care. And that's where I would say we see the most. I think there's most room for improvement, and I think that's a place that consumers can really work in, which is, um, you know, a health plan will often say in its documentation that they are providing care based on standards of medically necessary care or clinical standards of care or generally accepted guidelines. That they'll say all sorts of things, but really what they mean is what we call this bucket called generally accepted standards of care. And so for substance use disorder care, for example, it would be the American Society of Addiction Medicine, or ASAM criteria. And ASAM criteria has very specific levels, and all levels of care should be covered. So a lot of times, like 3.1 and 3.2, which are like withdrawal management, those things are often, like, the health plan will just say it's not covered, it's not part of our joint sort of standard. And so if you know the ASAM criteria, you can start to kind of fight those and push those up yourself and say this level of care is the clinical standard, and here's this evidence. As of course, as consumers of healthcare, we shouldn't have to know all these things, but I do think it's really helpful to kind of come armed with this information and kind of knowing what you'll have to fight back against to kind of increase your odds of getting comprehensive mental health and addiction care covered. So that's kind of the array of things. And then if you have a federally regulated plan, there's the local EBSA, EBSA, which are Department of Labor offices, and they can also issue investigations. And then for some states, You can also go to the attorneys general in the state and ask for your case to be considered too. So these are, I know it's a lot of different things. I always tell people just to start with the regulator that's overseeing their plan and try to work with them and get as much information as possible. Oftentimes, plans will start to overturn before it turns into an actual denial. And the reason they do that is because they don't want to be seen as having really high denial rates. So, for example, in California, where I'm at, the regulator's external process is called the IMR, which is internal medical review. And close to 80% of mental health and substance use disorder appeals were overturned in favor of the enrollee or in favor of the consumer seeking that care. And those are really high percentages because people who have the time and energy and are completely exhausted by that process to continue through it generally get rewarded for doing that. So that's my plea to you that if you stick with it on some of these things, that your odds are higher than not, of course, that you will get at least some coverage. So I'll pause in a second. There's just a few other things that I know are pretty common. So, and then, depending on your state, you may or may not have a regulator or you may not have a law in place in your state that can give you these protections, but these are kind of generally gold standards that we try to push in state legislation or push regulators to the Kennedy Forum. One is around our Ramstad model bill. What that essentially does is say, that health plans must use those generally accepted standards of care, like I was just describing. They must use nonprofit clinical criteria like ASAM in order to make those decisions. And they have to sort of tell you what their crosswalk is for making that. A very, very common um, uh, tool that plans use is called MCG, or a lot of times it's Interqual. And those are proprietary. We call them black box formulas that the plans use. They're private companies. They work for the health plans to make medical necessity determinations. And they'll often say that their product is based off of the ASAM criteria or something like that. But it's more restrictive. And so that leads to really, really high denial rates for folks. And so that is one area that both the federal regulators have been very clear on and state regulators have tended to be pretty clear on recently, is that the health plan must use generally accepted standards of care like the nonprofit behavioral health criteria so ASAM's one, CalLOCUS for children is one, LOCUS for adults is another. There's some specific guidelines like eating disorder guidelines and things like that that are from the nonprofit clinical associations. I would highly encourage you, as you're kind of thinking through, what's necessary in an appeal, to think about what the clinical criteria is. And oftentimes your provider is using that criteria. They should be anyway. So I think that's a big piece too, is ensuring that you're kind of aligning what you're putting together with what your provider is providing, and hopefully your provider is providing the standard of care. And so you can, really ask for that from them too. I think I'll pause there. I can talk a little bit if there's interest about sort of what you can do with your provider in terms of single case agreements or things if they are out of network, because I know that's a very common thing too for mental health and addiction coverage. But I'll pause because I know I've thrown a lot out. If there's any questions or anything that is interesting that you would like me to talk more about.
Thank you, Lauren. So I think what I'd like to do is introduce Daryl Rogers, because Daryl and I had a conversation prior to this meeting, which kind of drove my desire to have this meeting as it was. So he is a peer recovery family advocate. And so he's working with families and having a lot of these issues. So Daryl, if you don't mind, I'm going to turn it over to you to kind of talk us through exactly what we talked about and present your questions to Lauren and some of the situations you're facing.
Okay, okay. So I'm a family recovery coach and an interventionist. I'm fairly new at interventions. Been doing the family recovery coaching for a little while, and so and my son passed away in a marijuana impaired wreck. He was 20 years old, and that was in 2014. That's what led me into this line of work. So I'm pretty. I'm not as sharp as I used to be on the issues around marijuana because I'm focused on other things now. But certainly, marijuana is when it comes to substances is at the forefront of my um, thought processes, and I'm always kind of keeping track of what's going on with issues around marijuana. And I do have a lot of parents who call me. And this is what, I brought up to Chrissy that I have parents who call me. It seems like an increasing number who call me have a child who is addicted to marijuana. And quite often it's only marijuana or, um, sometimes it's Delta 9, sometimes it's Delta 9 or Delta 8 or both. Um, and sometimes there are other substances, but quite often it's just THC and more reports of psychosis, more reports of cannabinoid hyperemesis, um, just a lot of issues around marijuana. But one of the things I was running into was that and I'm part of what I do is try to help parents select an appropriate treatment center for their child, based on all the criteria they give me, what they're looking for, what's in their price range, what would be the best, the appropriate level of care. And, um, a lot of treatment centers I was running into this issue with, well, insurance won't cover THC only addiction. And I'm like, man, that's crazy. This kid and when I say kid, he's quite often it's young adults, kids to me. But they have a serious issue here, and um, insurance companies aren't going to pay for that, and it's really crazy to me. Um, one workaround is if they have a mental health diagnosis, you can get them in that way. But a lot of times they don't. A lot of times they don't. And so I mean, it's just another roadblock to getting them the help that they need. And I called Chrissy because I'm looking for solutions. I'm like, how can we get these kids into treatment? How can we get, treatment is expensive. And sometimes it doesn't. Sometimes, unfortunately, it takes two or three visits to a treatment center for them to get the help they need. So, I mean, it adds up. You go to inpatient, and then you do, um, you know, sober living home, IOP, therapy, all of that, and it just adds up. So, um, when parents are having to pay out of pocket, a lot of people just can't afford it, and the insurance is not going to help at all. So that's kind of what led to all of this conversation with Chrissy. I called her up and I said we got to do something about insurance companies not paying for THC only, in their terms, THC only addiction. To me, addiction is addiction. Um, the behavior is much the same regardless of the substance. And, um, it's a little bit more serious, obviously. I think with some substances, but I think when I say more serious, more is like it's more of a crisis situation. In other words, they could overdose or their behavior is just a little bit more out there. But I mean, you got to look at, in the meantime, they're driving impaired in a lot of cases. Um, they're quite often isolated in their room, and they're depressed. They're not motivated to work. Still living at home with their parents, and it's just it's something we need a solution to.
Yeah. Uh, yeah, I also feel for the mental health community. I feel like has taken a lot of strides and like really professionalized around a lot of this stuff. And the local NAMI chapters, local Mental Health America chapters are really great resources and have been the source, frankly, of a number of our state bills that we've run. And so I think having the provider and parent voice on how hard some of these things are is not to be downplayed. We initially ran our bill in California, which became a model bill that was, now I think has been in 9 or 10 states, um, because of a mother who, was struggling to get her son into comprehensive treatment. And that her story is heartbreaking and her family story is heartbreaking. And it's usually those are the stories that really ignite a lot of the change. So I don't want to make it sound like those are so important for starting points, and for really getting these things to change and to meet, you know, legislators and folks that can make those changes, with a lot of experience and drive and, wanting to be part of those solutions. Um, the addiction advocacy community has historically not been as connected to the mental health advocacy groups, and that could be stigma, it could be a lot of other things, but they are often seen, I think, is sort of separate, which I think is a loss for us moving forward as mental health and addiction advocacy, um, in that kind of change. And so I think there's a pull to, it's important to sort of attach. I mean, one of the biggest things that I do when I'm looking at new legislation is add in addiction. So it'll be like, this bill, requires that health plans do this for mental health care. And it's like this for mental health and addiction care. Like that it really sometimes is some of that low-hanging fruit of ensuring that substance use and addiction care is really just incorporated into the existing mental health protections that we already have set up at the state and federal level, and that can be a huge part. And I think when you're, fighting for health insurance care too, you'll sometimes hear insurers slip up about that. They don't think about that as different, or they don't think that it's covered. And so I think really knowing how to advocate for that as equal in care. So we talk about mental health parity between like mental or between medical, surgical and mental health, but it's also mental health and substance use disorder care too, and how, protections can kind of be looped in there. Um, as you're speaking, it sounds like we hear this all the time, but trouble getting your health insured to pay for oh, sorry, I don't know why it does that.
Hmm.
To pay for any health insurance care. And then you might get your kid into treatment and it may be a lower level than is clinically needed. That happens. So you don't get the level of care you need. Um, or you get the level of care you need, but then they make you do reviews at quicker intervals than is the standard of care. So as we know, addiction care and recovery, not only does it take a few shots at it a lot of the times, it also is not something that once you start to show improvement, you're sort of let out onto the street or back into your house, alone. It really, that's not the clinical standard. And so when I was talking about the general accepted standards of care, I think that is a huge, huge area for advocacy and especially parental advocacy around some of this stuff, because that's so deeply where plans cut things short and can make people's lives hell, particularly in seeking addiction care. So, things like making sure the right standard of care is being used, making sure that it's not at intervals that are more frequent than the clinical standard, and really getting so much of this in writing and making plans kind of show proof of why they're denying that coverage or why they're not going that far. And talk to many families, and it's heartbreaking every single time, of like folks who have moved their kid to a different state with them or changed jobs or, sometimes pulled their kid off their insurance so their kid could get better insurance through Medicaid because it's covered in the state's Medicaid, but not by their commercial insurance, right? Like there's so many sacrifices that have to be made that I'm really sensitive to on that. And also, I think there is a lot of ability at the personal level, if you can do it and you have enough energy to do it, to fight your health insurance directly on those things before paying out of pocket for them. And there are things like the No Surprises Act where um, you can ask for a bill from your provider, like an itemized bill, and then you can send that, like things that you just didn't have, they didn't have to do before. And I realize that sometimes you're sitting there fighting providers to get you the information you need so that you can submit the bill and kind of be the go-between. That can be exhausting. So um, I hope that's not coming off too much as a rant. I completely understand that. I think there are many areas for advocacy and then also many areas for self-advocacy and like fighting individual bills, and they all take a lot of time and effort and patience. And I have myself screamed on the phone at health plans from trying to get my own insurance care right. Like it's even if you're really well versed in it, it's just really a tough and infuriating process. So I think having this group and having, you know, some of those support groups like the NAMI and MHA groups where you're kind of working with folks that are in um, the same boat who have also had to learn to be self-advocates. It is a muscle that obviously you're here, you're all at least have some of that muscle developed. So I think it's really important and really important for you start to become that person that everybody in your network starts to rely on for help once you start to know these things. So um, kind of takes a village on a lot of that. Happy to answer questions specifically about like any of these processes or things too. I feel like I've been talking kind of like high level vague, but I know that that's not always how it feels for all of you.
So Lauren, I want to ask for the group, are there some, we try, organizations like Aubrey's, like myself, we try to provide one pagers, documentation that makes it easier for these parents to understand,
Yeah.
have talking points. Are there documents that you can send to me that we can attach to this webinar follow-up when we send out the recording? Or particular links that you think are useful from the Kennedy Forum website?
I can certainly send you some things. I will say because we engage more with regulators and advocacy groups on legislation and moving some of that stuff forward, more of our materials are that and less so on like consumer materials or know your rights flyers or information. I know that the state insurance regulators' websites are not known for their beauty and simplicity. But they often, like if you type in just state of Virginia, consumer rights, mental health, whatever, like a lot of the search engines do a really good job of bringing those up, and they will give you like direct step-by-step instructions of things that you're entitled to as a consumer in
Right.
your state. And so that's a really good place. We should do more for building consumer materials because I think it is really helpful to build those things up because it can really feel like, you know, drinking out of a fire hose.
Mhm.
Um, yes, there are areas too, if you're interested in sharing your story, the Kennedy Forum is um, our communications team is amazing and works with talking with families through like just sharing their story because I think that can be really helpful. And I often will sit on those calls, and if there's anything that comes to mind, like technical expertise or things, I'm not an attorney and I don't represent, but like I'm happy to help kind of as you're thinking through what's going on in your specific case, things that come to mind that might be helpful. And sharing your story is really important. So we usually try to tag team those things together. So if folks are interested, they can reach out through the info at Kennedy Forum website.
Be careful what you wish for, because between me and Aubrey, we have thousands of stories.
Well, we'll try our hardest. Thousands might take a while to get through, but so far when people come knocking, we've been able to work with them. So
If anyone has a question, please just unmute yourself and ask away.
Hi, Lauren. Is it okay if I ask a question? I really want to back what Daryl was saying, that we just don't even know where to start and how, what's the family's budget? And like you said, Lauren, everybody's exhausted and just like I was wondering with the resources you're gonna send Chrissy, I was wondering if like because a lot of the language you use is foreign to a lot of the families. I understand it because I've been through it and I couldn't find treatment for my son. This was back in like 2015 and 16. So I had a friend who was a social worker, and she says, as a taxpayer in the state of Colorado, you can volunteer your family for crisis intervention with the Department of Social Services. But she says you will never find a treatment program that'll take your son for his cannabis use disorder. And I did that, and it was some good, some bad, and a lot of parent shaming and just kind of minimizing marijuana's effects on his brain. But I was wondering if you could just kind of lay out like the structure, the outline that you gave us, if
Yeah.
you would be willing to do that, just to kind of give a template, like a footprint for the parents that Daryl and I work with and Chrissy works with that, even though it might not be a perfect process, because it does sound like drinking fire on a fire hose, but like I didn't, like in my certain situation, I was so exhausted. I did try to get reimbursement for his like outpatient services for a while. And it was like a hitting the wall every time I would make a phone call. And I just had to like take a step back and like I can't do this anymore. So we ended up losing all our equity through this process and sold both the homes that we had. And now we're just like rebuilding our lives back. Thank God we are, and we have that opportunity to do that. But like just a step by step, kind of the way you took us through that in the beginning, so we can have like a roadmap kind of thing, like start here, start there, and then what this language is and a little bit of a definition, what it means. I know it sounds like a lot of work, but you're very educated on this. And most of the families that come in contact with Daryl, Chrissy, and they didn't even know marijuana was addictive in the first place. And then they're like a deer in headlights. They're shocked. They're living in a state of fear. They're not understanding why there's policies promoting this poison, and here their kiddos or their young adults are addicted and in psychosis and physically sick all the time. And it's a total nightmare for a lot of
Yeah.
families.
And this isn't a perfect answer to any of this, of course, because there isn't one. But for what it's worth, I think where we've seen the most areas of success, and I guess I'll back up. I know that's also really hard when you're like, I need to get my kid into treatment now, and I can't wait months. And we see this a lot for like substances that the kids are overdosing on. They're often in the emergency, things like that, where it's like it's truly horrendous, and they still can't get their plan to like engage with them in any timely manner. So I know you brought up emergency services. That is one area, but you don't ever want to be in that position either, right? You want to try to do preventative, more upstream things. And I think the nature of a lot, all addiction is that there are underlying or co-occurring mental health things that go along with that. And I think that can be some folks feel that that's stigmatizing. I think sometimes separating them can be stigmatizing and that you're only caring for one specific area and this other areas. Like if we're thinking about like health of a whole person, um, a lot of the diagnoses and things that can kind of happen around that, even if you can't get a specific diagnosis for cannabis use or other things, could really help open the door for some of that care that's very relevant to the folks that to your own personal experience, to the folks that you're working with and talking with every day. So I think for what that's worth, it is worth sort of trying to group those things together and think about like, okay, my kid, here are all the things, here are the diagnoses, here's all the and then putting that together sort of um as building your case. That's really what it feels like you have to do for your health plan is like this is like you can't just deny this one separate thing. You have to think about this is the kid, this is the case, this is the one person you're looking at, and the health plan's just looking at these things as numbers and itemizing. And your kid, all the things that are going on. The provider often does too. And so as much as you can kind of bring that material together and try to make that case, I think it is a lot easier to sort of build that argument for the plans. And sometimes they can be very responsive. I don't mean to demonize them all the time. I think it's easy to do that in my field. A lot of times they do want to do something. And so appealing to that and trying to figure out what that is. But I know it's really hard when there's not more consumer facing materials that really walk through the process, and it can be a lot. So I'm happy to try to pull up something that we think is useful. It's also hard because we're not attorneys and don't represent, like, every case is different, and so we have to be a little bit careful. But existing state regulators do tend to have these things. And then I think I'll bring it up because I know you said you're in Colorado. Colorado just passed a very comprehensive series of, calling them parity or mental health substance use disorder access bills that really get at some of those key components where they have to sort of, the health plans have to prove they're using that nonprofit standard. So they're using ASAM criteria. They're doing for the full course of treatment. So Colorado is one of the leaders, and their insurance commissioner has really focused a lot of opportunity on that. And the current governor has made an effort. So I think for what it's worth, you may be in a position to really push that, and to sometimes even just referencing those bills in that language can be really helpful. I've had a number of families that we've talked to that just said, my rights under this bill, and suddenly it starts getting covered. So where you do live in states that have more of those comprehensive protections, so Washington, Colorado, California, Illinois, Virginia, Georgia, Ohio has some of that, not in statute as much, but their regulators really trying. New York, things like that. And if you live in a state that isn't what I just said, that doesn't mean there's no hope either. It's just that, those states have a little bit more substance in their state laws for long-term full care, comprehensive care, care that's tied to clinical standards and guidelines. Forcing an insurer to explain why they're denying care, and so you can fight them because you know why they're denying that care. Can't pull the kid away from care too early, things like that make it a little bit easier. And I'm also happy that we do have the Ramstad model, and other state bills and things that, if you are interested in doing advocacy around that and kind of working in your state with mental health advocates on these issues. I run a state parity work group once a month that talks through some of these issues and has a lot of advocates on it, and folks that are trying to run bills to sort of change those things. And so if there's interest there, happy to send links to that too for people to participate in. But yes, absolutely, we should have more documentation so it doesn't feel so overwhelming. I don't know if I answered. If there's anything else you want me to detail, happy to talk more about it. I feel like
Yeah.
I maybe directly
Ye-
answer.
Yeah, no, I'm just wondering if, like, what you're talking about, if you could just put in an outline and just, maybe if you send it to Chrissy, then we can, like, look at it and organize it to, so it's not so much a drinking from a fire hose. And it, so like, just even the language, the terminology you're using, because, like, I know, like, I'm trying to write it down while you're talking about it, like, go to the regulation commissioner and stuff like that.
Yeah.
Just to say, just to kind of give a list to the families, like, here's a list of resources to check into to see if you can get your treatment reimbursed. And what I have found too is if the family has money, they're going to get treatment, anywhere they want to get treatment. They've got thousands of dollars to come forward with. That's no problem. The treatment's there. It's the families that don't have the money. I mean, even if they have good private insurance, I remember the one dual diagnosis program that I had my son set up to go as a working ranch. I went and bought him ranch clothes, had him ready to go, and they called me the night before, the director, and said, unless you have $12,000 each month for 3 months, so they wanted 36,000 to bring him. They weren't even going to let him walk through the front door because they're like, insurance companies don't pay us in time. We need to keep the lights on. We need to keep our employees you know, have their paychecks, so they will keep coming to work. And there was like, okay, no, I don't have 36,000 in the bank. I was at home. My son was so violent that I couldn't leave him alone home with my younger son. So I wasn't even working at that point. And it was just, you know, a living nightmare. And then, you know, you turn it around and everybody's like, oh, it's just marijuana. It's just marijuana. And it's like, yeah, but it's making my son like in psychosis, and like he's not rational right now and he's lashing out. So, um, I guess what I'm saying is, you know, if there's at least a template we could put together, or a roadmap, so we can start somewhere, even though it might not be perfect and not as comprehensive of probably the knowledge you have for that. And then like, maybe, I don't know, Lauren, if you do some consulting with the families too, or if there are people that will consult with a family to guide them on how to get reimbursement or anything like that, or other webinars like this that we can send them to.
I think Chrissy put in the chat, was it Chrissy, for the Partnership to End Addiction roadmap? They have a number of resources, and we've talked with them and worked with them on a few of these things. So that could be a good starting point. And
Okay.
then it's been mentioned a couple times, uh, psychosis. I will say that that is an area that we're working especially hard on. Coordinated specialty care for first or for early episode psychosis is the clinical standard, and we're working very hard with getting commercial insurance reimbursement for that. I will say that a number of the large commercial carriers we know already have it coded into their systems, which is huge. That's a huge barrier. Sometimes they just don't have it coded, and then so they can't even talk to each other or understand what's going on, and so then you just get weird denials or all sorts of things that are happening that prevent you from getting that care. Um, Coordinated specialty care is also a like comprehensive, like wraparound, family engaged, lots of comprehensive services. Um, like a whole person model. The federal government has issued numerous pieces of guidance saying it should be covered. The Department of Labor has reiterated that. Many state regulators have reiterated that. It's so highly studied for early psychosis, and it doesn't really matter what triggered the psychosis to get coordinated specialty care. And so I do want to put a plug for that, because that can be a really life-changing resource, and there are a number of providers in many states that are working exclusively on that and have coordinated specialty care clinics. A lot of times they're at like university health system, things like that. And commercial coverage for that is really tough too. So that's a component that we're actively working on at the Kennedy Forum and have some resources on specifically. So I'm happy to share those too. But again, because most of our engagement isn't with the direct, we don't work directly with families and consumers to like walk through their appeals very often. We tend to do that just by the nature of kind of what we've done, but that's not where a lot of our work has traditionally focused. And so I think there's what I'm walking you through, we have less written down resources for, but I do acknowledge that we do need to have more of those. But the Partnership to End Addiction has many things that are very good, and we don't not do it at the Kennedy Forum. It's just not always our um, biggest focus. And the local NAMIs and MHAs also put out many things around this, but specifically NAMI on coordinated specialty care if you're looking for resources for that.
Yeah, and I will add to what Lauren is saying that, believe it or not, one of our consultants works for the Partnership to End Addiction. She's a consultant now, but she's the former director. And so it was her idea to do this webinar as well. So we met about this, and she unfortunately couldn't be here tonight, but we look at this as the first in a series. And when we send this recording and the link, we will send a variety of one pagers from the Partnership to End Addiction that do address what Lauren is talking about, but more at a level for our parents to understand for sure. So, I mean, while I think it would be wonderful, Lauren, if you could put together one document with some of the language that you talked about, even if it's just some bulleted points for me and I can put a document together, that would be awesome. But we will provide resources with the recording.
Yeah, we can certainly work on something.
Great, thank you, because I know you're very, very busy, so, but again, I can absolutely work with your bullets and just make it into a document accessible for our parents.
I have one more question. I'm so sorry. And one of the feedbacks we get from the families too, instead of their loved ones being diagnosed with cannabis-induced psychosis, the ER physicians are diagnosing them bipolar right away because they're saying that they can get more treatment coverage, keep them in the hospital longer, and get reimbursement better for that bipolar diagnosis instead of a cannabis-induced psychosis diagnosis.
What's the question?
Well, I'm just making a comment. I'm asking you
Oh.
if you hear the same thing. Like, is that why? I mean, do we bring on lawsuits for that kind of stuff, or what do we do to?
Yeah, I feel like I say a lot. Not an attorney, cannot speak to that, but also not a clinician. So I do think I'm sure that experience is happening a lot, and that's coming from providers trying to open up a window for coverage for that care. And I think the reality is in the current state of how we treat mental health addiction care that you can get better coverage. A lot of these are co-occurring. It may be presenting as bipolar, and so you treat it as bipolar. A lot of the medications are the same, or things like that. And yes, maybe it's not quite that. Maybe it's something else, but that's sort of the treatment pathway that gets followed in order to get that kind of coverage. Um, I can understand why it is that way. I think a huge issue that continues to happen, and it happens in the Medicaid space too, um, is that you need a diagnosis in order to get treatment a lot of times. And there's a big gap in needing treatment and getting that initial diagnosis, and diagnoses change and things like that. So I think what you're seeing is providers trying to operate the best they can in the reimbursement structures that they know work. And as you're all aware, cannabis specific stuff doesn't get reimbursed from health plans very often, unless it's connected with other things. And that's why I mentioned that, like, connecting it to other care for co-occurring care, in order to try to get that care covered. That's how providers are often working too. And a lot of the treatments are very similar for good reason. They're a lot of the same sort of activations and things in the brain. So, um, you know, I feel for that. I understand why they're doing it. It may not be the perfect solution. I also understand that many, many people are paying completely out of pocket for care that their health plan really should be covering by law as is. And so you're kind of seeing a lot of gray area, and you see that gray area happen a lot in the emergency room. So, um, yes, I guess
Mm.
not a direct answer either, for maybe not a very specific question either, but it's a tough spot to be in, and I understand why it is that way. The clinical standards of care I talk about over and over are a really important way to sort of move that forward, though, um, because those are guidelines for every step of care that's needed, and they're not necessarily contingent on a diagnosis.
Thank
Daryl,
you.
did you have something you were going to say?
Yeah, I was going to say something. I was kind of on the same wavelength as Aubrey there, and that I think I mentioned earlier that that can be a workaround for parents if they can't, get the treatment for their children that they are for their child that they need, because it's THC only addiction. They can, if they get a mental health diagnosis, they can. That's sort of a workaround. However, you sort of need to be careful with that too, because like Aubrey was saying, I mean, a lot of times it presents as maybe it's bipolar or something along those lines, but it's not an accurate diagnosis if they've been using. I mean, they really need to be sober for at least 30 days, sometimes longer, to get an accurate diagnosis. So, I mean, you don't want them to get a prescription for psychiatric drugs that they don't need. But yeah, if that's what you have to do to get them into treatment, I guess, for right now, it is one workaround.
And I did mention the nonprofit guidelines for, and then someone else in the chat said there needs to be a difference between under 18 and over 18. Agreed. There are different guidelines for over 18 and under 18, and that's for good reason. And so the under 18s are CalLOCUS, so the children's locus. And a lot of those are sort of developed, and I shouldn't speak so much on them because I don't know them deeply, but very familiar with them. The CalLOCUS guidelines are usable without a diagnosis too, and so that kind of makes it a lot easier to move around because of child development and things like that. So that might be an area to look into. They're huge guidelines. They're the American Academy of Child Wellness and Psychiatry updates them and things like that. But they're very specific levels of care. So even if you know your kid needs a specific level of care and your provider knows your kid needs a level of care, like being able to point to that and asking the health plan to prove why they don't meet that level of care is a helpful kind of dialogue you can have with them, or in the appeals process, because a regulator may be much more willing to side with you. But health plans don't want to have to go through that process too. So you just have to be more annoying. The potential for you to be more annoying to them sometimes helps, which annoyingly kind of is how life works, I've found out. So be the annoying bug and you get pretty far.
Well, I just want to add, Lauren, thank you. You are a wealth of information. I've learned a lot, and I just wish I had your brain with all that information in here and organized. And I really appreciate your work. The space you work in is so critical and life-saving and valuable. And so thank you for that.
Yeah, thanks for the nice words. One other thing I'll say, because it's come to mind, I know that a lot of people have to give up their jobs and they spend many, many hours fighting all these things. There are a number, I don't think I realized this before being in this field, but there are a number of um, like advocacy groups or like folks that kind of help bring cases. So like they could be attorneys, but they could also just be like sort of helping on appeals and are specialists in appeals and things like that, that take clients. And so of course you pay them, but then they're helping you kind of win appeals and figure out commercial coverage. And so depending on the severity and the length of the case that you think it'll be, those sorts of groups can be really, really helpful and meaningful, and also something that you don't have to worry about because they're doing it. So I think probably for some folks, that's a good use of resources if you have them to do that. And I know all of this feels like an investment all the time. It doesn't actually matter how wealthy your family is. For most folks, they're spending like everything they have to kind of meet that need. So I understand that can be really tough, but that might be something that I just wanted to note because you could Google around and not really know that those folks exist. It's not the same as kind of just having like a injury attorney. It is really different, and they're not like bringing things to a court. They're trying to help you with your insurance. So
That sounds kind of like civil, Aubrey. Is that what you were thinking too? So they're marijuana focused on helping parents in this space. Could you give us an example of one that you're talking about, or are you just speaking in general?
I can give you one that maybe isn't helpful for you all, but they're a great, like it's a good example of seeing like what kind of services they offer and like resources they have for consumers. What's called the Mental Health and Autism Insurance Project. So they do a lot around autism care, which is another field very historically under reimbursed for the care that they need.
Mhm.
And I think they're just a pretty good model of how how to sort of go about those things. And they really help with advocacy too. So like they have helped us with a number of our state bills and making sure that those things work. So places like that I think are important. And I cannot vouch for these at all, but they're a resource that's come up more is sort of these like tech AI companies that will take your appeals and kind of work with their systems to try to just automate the process of going back and forth with your health plan to try to get coverage. Not an advertisement for them. I really don't know much about them, but they do seem to have good results and are a cheaper end of that model from than having a specific consultant kind of work to do those things with you. So want to mention all the resources that are possible because it may change a life. So worth looking into.
And that's the Mental Health and Autism.
Insurance Project. There's a few groups like that. They're the one that comes to mind, kind of on the number of things they provide. And then there's certain like law firms and things that work on this specific stuff, but I cannot give names for those because I don't want to endorse those.
I'm interested. It's interesting that you mentioned this Mental Health and Autism Project because Aubrey and I are both thinking the same parent because we have a parent whose son is nonverbal, adult, autistic, used cannabis. It's a disaster story, and this could be valuable to her.
Yeah, it might be worth reaching out to their founder. I'm happy to connect you all. She's a really inspiring person and has worked really hard to sort of build these things up and has been really successful. So kind of proof too of if you have endless energy and optimism about how to change a really crappy system, how far you can get. So
yeah, well, look at us here tonight, right? So endless energy and dedication to this. So does anybody else have any other questions? Rhonda, did you want to say anything or ask anything?
Thank you. I'm so sorry. I just ended my caseload for the day, so sorry for being late. But I have like over the last year, I have had an increase of PANs and pandas, and not necessarily relatable to the cannabis piece of that, but just kind of understanding like I'm pretty much using cognitive behavior therapy to help them, but I really don't know like what else is really out there and to find information to kind of know what else is out there to help the provider help with all this. I don't seem to be making much headway. I'm pretty seasoned as a therapist, so and I'm not quite sure like what modalities seem to be pretty effective for treating so that when I'm in the room with them, because if I do like a symptom checklist and I'll say, how are you doing here? Fine. There is no, like, it's just a flat line, like just of, and so to help me communicate better with them, I want to know like where do I go? I wrote down, I went to the things that you said to me, like, I'm going to write you, I will write you, but I need help because I don't know all the things. And I don't proclaim to try to think I do, but my heart just aches for these moms where like, my one case that I have is he's, I think he was 17 and, he never graduated. He's now 20. And I don't see him to be functional, to be able to be ever on his own. It's almost like the idea of like, while he can communicate and he can do some things, but he can't make decisions for himself anymore that are effectively healthy, right? So what kind of things are out there to help with
Mhm.
this? Because in the last year and a half, it's increased. Like I'm like, what is happening that we're seeing an increase?
Can you remind us of what PAN and PANDAS stand for, I mean, there's only a few of us here, but just for anyone who doesn't know what that acronym is.
So I have to go back and look it up. So I'm gonna go and do that real quick while I'm talking to you. Um, so PAN stands for Pediatric Acute Onset Neuropsychiatric Syndrome. And while PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Strep Infections.
Huh.
So those are the two differences, and that's kind of where I don't know if I kind of lost you now. I got to figure out how to go back and find you. Oh,
Well,
here
we
we go.
can hear you and see you,
Okay,
so
great.
we're good.
So I'm just so sorry. I got all these tabs open on my computer. But like, and so I don't know if, and so I went out seeking. And so then I found you, which made me then register for this webinar. And I'm thankful, but it's my start to like, I want to know what else can I do? And I need help.
Mhm, mhm.
And
Well,
I'm a mental health therapist trying to like ask, where do I
yeah.
go? Yeah.
Yeah. And that's a lot of our membership for agencies like Every Brain Matter, myself. Daryl, of course, is a recovery family advocate. And yeah, if you just contact me, again, we don't really give out we're not doctors, you know, and
Sure.
but we have resources between the multiple agencies, and just send me an email and we'll arrange for a Zoom meeting and we'll talk about some things and see
I
what
would love that.
yeah,
Thank you so
of
much.
course.
Thank you.
And then of course I highly recommend exploring the Kennedy Forum website and Parity and everything mental health that is on there as well.
Wonderful. Okay.
Yeah, and
Yeah, I
I'll
did
make a
copy those
plug.
and bring those over.
Mhm.
I'll make a plug too for um, provider advocacy groups. So like state MFTs or other groups that kind of meet, because then they also are sort of responding to some of the emerging needs, and then they do a good job with advocacy and like legislative stuff. And so that might be a good place to go for both resources and to kind of get involved in more of the other things that we were talking about. Because you're a provider, I will also make a note that I think I said this at the very beginning, so you might have missed it, but like kind of the thing that I end up having to do, I think, is just, nature of this job, and that I'm like not fun at like parties anymore because I like will talk to people about this. And they're like, "What do you do?" And they're like, "I'm a graphic designer," and I'm like, "I do this," and then I end up having to, walk someone through like a health insurance denial. Um, is that the number one thing I tell people is sort of like guidance on how to talk to their providers to try to get coverage. And I realize that like caseloads are huge and there's all sorts of things that are happening all the time that make it really hard and difficult I might have to go just in a second here. My dog is starting to look like she's up to no good over here. But like being open to doing like single case agreements or even doing any sort of engagement with health plans to sort of give your documentation, your paperwork. I know it's horrible, but it makes a huge, huge difference. And providers are sort of saints for even considering some of this. And I completely understand why a lot of them don't even bother because it is horrible. But I think like especially for cases where there's big okay, I'm gonna have to go in a second. It's important to make sure that you're where you can, you're able to kind of help be that resource to the plans when it's possible. So um, anyway, I'm definitely gonna have to go now because my carpet is now getting ripped up. Puppies are so fun. But it was really nice to talk to you all. I know I'm already over a little bit over, but thank you for the work that you do. Really appreciate all of your, involvement in this. It's really helpful.
Thank you for
Thank you,
everything
Lauren.
you do, Lauren, and thank you for being here. And we'll be in touch and we'll follow up next week.
Okay, sounds good. Bye.
Have a good night. And thank you to all of you for being here. Again, Rhonda, just get in touch with me. We'll talk some more. Daryl, Aubrey, April, thank you for your input and for being here. And Kathy as well, good to see you. And next month, I think we will just, we might replay this webinar. It all depends. Keep listening to our Fortitude podcast. Again, these are all things you'll learn about soon, Rhonda. And look out for June's newsletter. And we look forward to seeing you all and working with you all in the future. And we hope you have a good June.